Hello, everyone. We are officially live. Welcome to another episode of Beauty of Breathing. Let's go live on Instagram real quick. Oh, and there she goes. Capri is making her appearance. Well, today we're excited to welcome Dr. Shelby Harris, one of the nation's leading experts in behavioral sleep medicine. She's a board-certified behavioral sleep medicine specialist, licensed clinical psychologist, and clinical associate professor at Albert Einstein College of Medicine. Dr. Harris specializes in evidence-based, non-medication treatments for insomnia, sleep apnea, circadian rhythm disorders, and other sleep challenges. She's also the author of 2 books on sleep health and a nationally recognized speaker and media expert dedicated to helping people achieve healthier, more restorative sleep. Dr. Harris, welcome to the Beauty of Breathing.
Thank you. Thanks so much for having me. I'm looking forward to talking.
So our topic today is behavioral treatment of insomnia. Dr. Harris, you've spent your career helping people sleep better. What first drew you to sleep medicine and what continues to fascinate you about it?
So I was first drawn to sleep because I was a sleepwalker as a kid, pretty bad sleepwalker a lot of times. And then when I had just graduated from college, I took a year off between college and graduate school. And I was put on a research study that looked at treating insomnia in people who were in early recovery for alcohol dependence. And we found that I was going into rehabs at the time, and we found that in the study, if you treated their sleep issues, their insomnia early on in recovery, it actually helped to reduce relapse rates. So a lot of people go back to alcohol, they found, because they weren't sleeping. And so we really targeted the sleep as part of the treatment. And I just thought to myself, this was like more than 25 years ago. It's like, why are we not talking about sleep in other areas at that point? And so it made me, when I went to graduate school, I was looking for graduate school specifically that had some sleep training in it. There weren't many, there still aren't. And that's kind of what just continued it from here on in, because when someone is sleeping better, you just see how many areas in their lives it really impacts for the better, that it's like the most rewarding.
Right. I always tell my patients that we talk about nutrition all the time and we talk about working out all the time, but not necessarily sleep. And I feel like sleep is more important than the other two, because if you have a horrible night of sleep, you're less likely to work out and you're less likely to eat healthy the next day.
Yes, I will often describe it. I've done this for a long time. Like, people talk about the pillars of health, like nutrition, exercise. They put sleep there, mental health. Excuse me, losing my voice all of a sudden. I always think about sleep as being the bedrock, actually. It's the thing that the other pillars are built into, because if you don't have a good solid foundation, the other stuff is going to be shakier. So
I love that.
It influences so much.
Another thing that one of my mentors says is that your day does not start when you wake up. Your day starts before you go to bed. Because again, if you have a horrible night of sleep, it's going to affect the rest of your day.
Yeah,
so
for sure.
Paying extra attention and doing everything that we can to allow us to have good quality sleep is so important. Exactly. Everyone says, though, that they're exhausted these days. Why do you think we're sleeping worse than ever?
So there's so many reasons. So one, I think the biggest thing is stress, and also just with phones in our lives, it's not just having a blue light in our face. That's not my biggest issue. It's that we don't turn off as a result. So we have more stress, and then work is no more like a 9 to 5 kind of thing because of the phones. We're constantly on. We never get a moment to turn off. And because we're busier than ever, people are just sandwiched with helping with their families, their work, a million things at once, that sometimes they bring it to bed with them. They're stressed and they're just not sleeping well. And then other times we have so much to do that people aren't making time for sleep. So it can be also an issue with getting enough sleep or having trouble with sleep when you actually try to. So we see a lot of both going on.
But at what point does I'm just a bad sleeper becomes an actual sleep disorder?
Usually it depends what we're talking about. Like, do you have insomnia, sleep apnea? But usually if you've been trying to practice good sleep hygiene, right? So you're limiting caffeine, limiting alcohol, all the stuff that people talk about all the time. If you've been doing that for about a month and you're having 3 or more nights of poor sleep, then you should definitely get that evaluated.
What is the biggest misconception people have about insomnia?
There's a bunch. So I'll go with two. One is that it's trouble falling asleep. A lot of people think it's just, I can't turn my brain off and go to sleep. It's trouble falling asleep, staying asleep, or waking earlier than you want, or a combination. And the other thing is that medication is the only way to treat it. And it's not. So it's actually not even the first line treatment for many people.
So what is the first line of treatment for many people?
So I love cognitive behavior therapy for insomnia is really, it's the gold standard by most of the big name societies. So American Academy of Sleep Medicine, the Menopause Society, I mean, their guidelines are for CBT. So it's really, when you're working with someone for insomnia treatment, it's very short term. I typically say 4 to 8 sessions. I kind of give a range.
Okay.
But it's generally a very short-term treatment. And once someone learns the techniques and the tools to be able to improve their sleep, it is longer lasting. So if you have to expect someone to never have poor sleep again, I think is unrealistic. But if you ever have an episode of poor sleep, you know what to do to get yourself back on track. Whereas with medication, for many people, when you stop the medication, you haven't learned other techniques and skills. And we don't want someone on medication long-term if we have other treatments that have a lower side effect profile long-term.
You've said that trying harder to sleep often backfires. Yeah. Why does forcing sleep actually make insomnia worse?
Well, effort, I say it all the time, sleep collapses when you put it on demand, right? So one of the things I like to ask most of my patients with insomnia is before you ever had insomnia, some people have had it most of their adult life, and I can't remember a time before having insomnia, but I'll say, before you had insomnia or your significant other, what do they do to fall asleep at night or to fall back asleep? And they're like, I want to know the secret. I said, well, ask them what they do. 9 times out of 10 people say they don't do anything. They don't do anything. The more that you think about it and try to make sleep happen, you're tensing your body. You're making your brain get more frustrated. Anxiety, frustration happens. And that's all stuff that goes in the exact opposite direction of what you need to have happen for sleep. So it's almost like you have to unlearn trying to sleep. We want to have you essentially let go of it, and then sleep will happen on its own.
So can insomnia actually happen in the brain and in the body?
In the brain, how? From a psychological standpoint, you mean? Or
from you just waking up, not being able to go to sleep, but you mentioned your body tenses up. Can people be creating that?
Yes, they can. So if you're waking up and then it leads to frustration, or you're like, oh, it's 2 a.m. again, naturally we'll get tense a lot of times. If the thought is, oh, here we go, I'm annoyed, that kind of thought. Yeah, the tension just doesn't help.
Can you explain to us the cycle of insomnia that keeps people stuck for years? Because it's one of the things that seems to keep people, and they just can't find relief. Insomnia seems to be one of the worst ones that we hear people complain about.
So there's the model by Art Spielman, who passed away a number of years ago now, but he came up with this model for insomnia. Essentially, there's 3-factor, 4-factor, depends who you talk with about it. But essentially, it's when you start out having insomnia, something happens that causes it. Some people can't figure out what the actual thing is that made it happen, but it could be biologic, like a menopause, for example, my area of specialty, right? So menopause, perimenopause might make it happen. But then what happens is, even though there was initial stressor, physical, mental, whatever it might have been, then we start doing things to try and compensate for the fact that we're not sleeping. So you might be going to bed earlier. You might be sleeping in the morning. You might start having sleep effort, right? I have to sleep. Why am I not sleeping? Then compensating during the day. So caffeine, taking more naps if you're able to, or trying to nap. So all those things that now have started to develop after a few weeks or a month of not sleeping well, those are the things that usually are continuing that insomnia to happen long term. So even though you might have had something that might have started it. There might be other things that are perpetuating it and maintaining it. And that's the stuff where CBT for insomnia actually really works. So it's the things that are continuing going for decades on hand for some people.
I've been hearing of some apps with that do CBT now. Or how have those been effective?
Yeah, they're great. It varies. So like there's the CBTI coach app by the VA. Some of my colleagues worked on. They're great. They're not for everyone though. So I think the apps are really wonderful for people who have either they're struggling with getting access to care, to seeing someone like myself, or they're just not necessarily early on. They're really good if you have early onset insomnia, but you're not using lots of medications. You don't have lots of like sleep apnea or other sleep disorders or a lot of complications. They're pretty good for that. Those are the patients that I don't usually see in my practice. I see the more complicated cases. So the apps are usually a good first place to start, though. We have a lot of good data suggesting that they're really useful, and I've seen it help a lot of people.
Amazing. How do anxiety and sleep feed into one another?
Chicken and the egg, right? So you might be anxious at night, and then you wake up. What I hear all the time is like, oh, I woke up at 3 a.m, and then I started rehashing all the things that I've done wrong in my life or that are annoying to me that I have to do. But then you don't sleep as well because you're up rehashing it all. And then when you don't sleep as well, guess what? Your threshold to be able to tolerate daytime stressors reduces. So then you have more stressors and you're just kind of feeling things more. You might have more trouble doing the things you need to do during the day. And then guess what? You carry that to bed with you, and then it just becomes a cycle.
Most of our listeners are interested in airway. So for airway focused providers, what is one thing you wish that they better understood about insomnia?
That it is... That's a great question for airway focused providers. I think that it's not just necessarily always like one thing that I think every patient's different. And I work with a lot of patients over the years that are, that have comorbid insomnia and sleep apnea all the time. And so we're working from an airway perspective to work on helping with their breathing at night while also working on insomnia, right? So maybe there might be something that's causing them to have awakenings, but sometimes then the insomnia might take over, whether it's their mind being active. So I think sometimes combining the treatments can be really useful for a lot of people.
Not everyone who has who can sleep has insomnia, and not everyone with insomnia has an airway problem.
Exactly. Thank you. Yes.
So why is that distinction so important?
Because I think when it comes to thinking about how you're going to work with the patient, you have to have an understanding of kind of what are some of the contributing factors. So there are a lot of people who are out there who will say, oh, I treat insomnia, but they don't even ask, like they don't know to even evaluate for an airway issue or apnea or whatever else might be going on. Because sometimes you do have to treat both areas if it has to happen, or you have to know, like I've had patients come to me many times that clearly don't have insomnia. They have something going on with breathing at night. And so then I have to know, okay, I don't think it's sleep restriction or any of that stuff's going to work. So I have to know when to send them. So you kind of have to know what some of the contributing factors might be to have them evaluated better.
And do a lot of people who have OSA, obstructive sleep apnea, also have insomnia? Is that common to happen together?
It's very common. I would say more often than not in my practice, people have both, believe it or not.
Is that comisa? Is that what they call it?
Comisa. Yep, comorbid, co-occurring insomnia and sleep apnea.
Very
and
good.
it's and the rates of sleep apnea increase dramatically in women when they start to hit perimenopause and menopause. And I specialize in that age range. So I see so many women that come to my practice. They definitely have insomnia, but I'm pretty sure that they have some level of sleep apnea going on that I then have to get them evaluated. And they're thin, they're fit, they're 45. You would never, like most people would assume, like I've had many of my patients say, oh, you don't have apnea, you're young and you're fit. And I'm like, nope, you'd be surprised. So
that is a huge misconception with obstructive sleep apnea. You know, we were taught to think that most people with sleep apnea are overweight males. But I think that people think that because they were the first ones that were actually studied whenever we started looking at sleep apnea. But we do see so many patients who are children or young fit women who still are presenting with the symptoms. I'm going to go just a little bit into OSA.
Yeah, please.
Are the symptoms between the old, overweight male and the young, fit female, are those symptoms that they present with a little bit differently? Is that where we're missing them?
That's where we're missing it. So women tend to report the symptoms differently. They don't usually say I'm sleepy, or they're not falling asleep. Like you would look at like an Epworth sleepiness scale. So that's the kind of scale that we look at for how sleepy someone is, which is debatable about using it all the time. But we'll look at that and like they won't be falling asleep all the time. And sometimes they don't have time to fall asleep, right? I was like, through my day. So women will often report more that I'm feeling very tired. I'm drained. I have no energy. And we know that sometimes with sleep apnea, we can see higher rates of people having some more anxiety, more depression. So they might report that. So they just get misdiagnosed a lot of times as, oh, you're in perimenopause, or, oh, that's part of natural getting older is to be tired. But they're not reporting that I'm sleepy. Or even with women, they're oftentimes not snoring, loud, choking, gasping. It can be much more subtle in some of them. So it just goes under the radar.
So going from this, you mentioned menopause or perimenopause. If somebody's going through that, what are some of the symptoms that could be red flags? Oh, maybe I am also developing. Is this more common for people to develop a new sleep symptom whenever they are going through those hormonal changes?
Yeah. So I do always ask, like, do you snore? Do you have any pauses in your breathing? Do you breathe through your mouth at night? Do you wake up with headaches in the morning? I see that a lot too. Any restless leg issues, if any of that's going on. But I do ask, like, how often are you waking up at night? How often are you using the bathroom, right, at night? Do you have heartburn or any sort of reflux at night? Like more of those kind of symptoms I'll see in patients. Do you feel like your sleep is unrefreshing? Do you feel like it's just not restorative? Is your sleep really broken throughout the night? Those kind of questions make me start thinking that there might be insomnia, but there might be other things going on as well.
Perfect. What is your opinion on sleep trackers? Do you usually ask these patients to track their sleep at home? Are the people kind of freaking out looking at too many numbers? Can they actually make sleep worse for some people?
Yeah. So in my population, I always make that kind of note. The trackers 9 times out of 10 are making people more anxious about their sleep, and they actually are not. I always say, like, is it changing anything for you other than making you more anxious? Do you ever find that you're learning something from it to actually change how you're sleeping? You already are limiting alcohol, you're limiting your caffeine, you're consistent with your timing. What new are you getting it from? What new information? You say, well, it just tells me how much I slept. It's like, you know this internally. You don't need the exact number. So I usually encourage almost all of my patients not to use them. Now, that being said, there are people out there. I have friends who don't have sleep problems. I'm a runner. I have a lot of friends who are runners and athletes who like to use them, the different types of trackers, to just kind of get some sense about their sleep, the regularity, how much, making sure they're getting enough sleep. And if they're not obsessing about it and they don't have a sleep disorder that's worsened, then it's like, fine, use it. It gives you a little bit of insight. But most people with insomnia, it's highlighting what they already know, which is not helpful.
Exactly. Okay. I have a ring, but I actually ended up taking it off because it's never charged. Seriously, like the charge lasts for 3 days, and I'm wearing it for 3 weeks. And first of all, I'm not checking. That I shouldn't be.
Yeah, that's a very different. Like if you're not obsessed about it, if you're forgetting to charge it, that tells us something. But I think that a lot of times the trackers are just getting in the hands of the wrong people. So I always say to like a patient, it's like, if you already make sleep a priority, do you need something to tell you to make it more of a priority? No.
Right. And just one more thing for me to remember: to one, charge, and to another one, track and look at it. He tells me when I'm about to get my period, which that's interesting.
Yeah. Like I think there's actually really good use for it. Like we've had patients be diagnosed. So they'll use it. I mean, it doesn't diagnose sleep apnea,
yeah, exactly.
But they'll see like, they'll see their oxygen have desats at night. Like they'll notice some of that stuff. And I think that it can be really helpful as like a tool. But for the average insomnia patient who's like, I just need it to tell me what stages of sleep, I'm like, that's not even always the most accurate. And like, how are you going to force yourself to get into more REM sleep? Like you can't just will it to happen. We need to do other things.
That's true. since we're both on Instagram, social media is full of sleep advice.
Yeah.
What is the one sleep trend or tip that makes you cringe?
Well, the worst one that I've ever seen, I've talked about it here and there, is the NyQuil chicken. That was a few years ago. It was I can't remember what it was, but people
I
were
don't know
cooking
what that is.
chicken breasts in NyQuil, like heating up NyQuil and cooking chicken in it. And they would be like, hashtag sleepy chicken, because I don't know, the chicken would make you sleepy and then you add NyQuil.
I thought it was turkey that makes you sleepy. What happened?
Well, it's a combo of the turkey plus all the stuffing and the potatoes. It's really everything, not just the turkey. But it's that was probably like the most.
I have never heard of that.
Yeah, don't use NyQuil if you have routine insomnia. Like that's not good either. But also, don't cook a chicken breast.
Chicken in it.
That was so weird.
I've never heard
it was
that.
all over the place for like a month. So bizarre.
I find that Americans really like to abuse regular medication. Like in Brazil, Halls, the cough drop is candy. It's sold as candy. It's not sold as cough drops. And over here, I remember watching on TV that some teenagers were buying a bunch of cough drops, and eating all the time. And I'm like, I grew up eating that stuff all the time. But they're always trying to stick something, find something. Oh my goodness, it's crazy. You just have to learn how to be Brazilian and be happy and party all the time without the pressure.
Exactly.
So women's sleep, you speak extensively about women's sleep. What do you wish more women understood about how hormones affect sleep? We touched on that a little bit, especially during perimenopause and menopause.
Yeah, I think one thing to notice is that sleep is one of the things that can be an early sign. Like I've had plenty of women in their very early 40s that would never think that they were going into perimenopause, where their insomnia was a sign that things were starting to change, and that changes in estrogen and progesterone, those are big changes that happen that can really impact your sleep. And then when it comes to like just accepting that this is how it is, no, I mean, yes, there is a natural process to it that sleep changes, but it doesn't mean you have to suffer. And we have many different ways to address, whether it's hot flashes, night sweats, waking up with a busy brain, whether it's CBT, whether it's hormone therapy for some people. And we also have non-hormonal treatments. There's a lot of options out there. Hormone therapy also isn't indicated for everyone, and it doesn't help everyone as much as some of the messaging online is. But it's that you shouldn't just accept that it's what's going to happen and that you have to like put up with it. We have lots of treatments.
I do have a question, personal question. Why do so many people wake up around 3 a.m.?
I know, it's funny. I used to get the question, it was always 2 a.m. Like, why do I always wake up at 2? And then all of a sudden, like over the past 2 years, it became 3 a.m., which I thought was interesting. A lot of times it's what, if people are going to bed around the same time, you finish a certain number of sleep cycles by 3 a.m. And a lot of times people are noticing, they look at the clock and they finished a sleep cycle and you naturally have a quick awakening. People have trained themselves a lot of time, but it can also be due to hormonal changes in the middle of the night, having to get up and use the bathroom. Like it depends on the person and what time they go to bed, but you've already been sleeping ideally 4 or 5 hours at that point. So it's like you're probably having some changes temperature wise, hormonally, and then maybe a natural awakening where you look at the clock and have trained yourself.
Is there one free sleep intervention that's more effective than people realize?
Getting up at around the same time most days. So it doesn't have to be exactly like, for example, 7 a.m. It could be 7, 7:30, but like 7 a.m., 8:30, 7, 9, like that's not great. But getting up at the same time is actually really useful.
Oh, this is going to go great into, which I'm going to change the subject from insomnia again. My kids are starting school tomorrow.
Oh, wow. Okay.
I know, we're in the South. School starts tomorrow. What is the fastest way that we can get them back to their sleep schedule?
I mean, I think if it starts tomorrow, it's just kind of hold on for 2 weeks. At this point. Maybe like aim for like a half hour earlier and just go in. And then I usually recommend like, because this is what most people like, you can do the gradual advancing. It's so rare that I find people that actually do that. You can do all that, but it's just go to bed a little earlier tonight, kind of wind down earlier. And then the other big tip that I give is that, so tomorrow will be Wednesday. Try the first weekend afterwards. They might be a little sleep deprived because of all the shifted schedules and just excitement. Keep the weekend a little lighter so that, like people will like overschedule the weekends right when school starts. I usually have people just keep it lighter, and that can make it a little easier to transition.
Perfect. Should I let him sleep in on the weekend?
How old are they?
12 and 6.
I mean, an hour, but not too much more than that. I wouldn't do too much more. The 12-year-old might start naturally shifting. But yeah, if you can keep them, especially now, like around the same timing, that would help, but maybe an hour later, not much more.
All right. Well, I have a couple rapid fire myth or facts.
Sure.
All right. So number 1, everyone needs 8 hours of sleep.
Myth. It's a range, 7 to 9 for most people.
Melatonin is a sleeping pill.
Myth. It's more of a sleep shifter. So we use it for certain things, but not always on insomnia for most people.
Sleeping in on the weekends catches you up on lost sleep.
Well, myth and fact, if you've only missed out on like an hour or two during the week, yeah, you can make that up. But most people are missing out a lot more over week after week that you're not going to be able to make it up on the weekend.
Mouth tape is the answer for everyone.
Myth.
Sleep trackers improve sleep.
Depending upon the person, but for people with sleep disorders, typically it's a myth right now.
Now this is a question. 1 sleep habit everyone should stop.
The most basic ones like using alcohol to help yourself go to sleep.
Perfect. All right. And 1 sleep habit everyone should start.
Keeping a more consistent within an hour kind of wake time most days.
Perfect. Well, if every healthcare provider listening today changed one thing about how they talk to their patients about sleep, what would you want it to be?
That it's not one size fits all, and that patients are good. They understand they're the best experts on themselves. So if they feel that a change has happened in their energy levels, their quality of sleep at night, send them for an evaluation from an MD, a sleep MD.
That is wonderful, Dr. Harris. This has been such a wonderful conversation with you. How can people find you?
So you can find me on Instagram at sleep.shelby. You can also go to my website, like Dr. Shelby Harris, drshelbyharris.com. And you can find me and my books and everything there, or on my Instagram.
And before we go, do you have one last message that you hope every listener remembers after today's conversation?
That if you feel like something's off, talk to your provider. And if they're just brushing it away and saying, it's nothing, get a second opinion.
Perfect. Well, thank you so much. And for everybody listening, if you are a professional wanting to learn more, make sure that you join our Thursday night lives, which are Airway Circles, online study club for airway professionals. Every Thursday, 8 p.m. Eastern Standard Time. This week, we have Dr. Karen Parker Davidson talking about nasal care in focus, evidence-based products, pitfalls, and promises. It was such a great conversation. So join us on Thursday. Otherwise, make sure that you follow us, Beauty of Breathing, on your favorite podcast platform. And thank you so much, Dr. Harris. That was wonderful. Have a wonderful day.
You too. Take care. I'll see you later.
Thank you.